most of your patients will be a little more mobile than they are in labor and delivery. Okay? When you do a maternal assessment, what you're going to do is what we call a bubble heave. Okay? B-U-B-B-L-E-H-E. Okay? You assess from the head down to the feet. All right? On mother baby, you are at a slight disadvantage because most of the maternal assessments are done at around 8, 9 o'clock in the morning, which you aren't there. They do, however, do vital signs again at 4, and any patient who is newly admitted to the unit will have a full head to toe done. So, if we can catch you with an admitting patient, that's great. We'll see what we can work on there. But, the bubble, okay, from the top. Provide privacy. And you uncover section by section, not all at once, okay? So, the first B in a bubble, you assess the breast, okay? You can see on this particular mannequin, we have done surgery on her breast here to configure it for some of our simulations, okay? One of our simulations is a breastfeeding scenario, okay, with problems with the breastfeeding. So, you have to assess the breast, and in order to assess the breast, you must look at them, okay? A lot of the nurses over on the mother-baby unit will say to the mom, how's the baby breastfeeding? Are your breasts okay? Do they hurt? They never look at the breast, okay? I expect you to look at a breast, okay? What you're going to be looking for, number 1, first of all, is she breastfeeding? She's not breastfeeding if you're not as essential, but you're going to know whether or not she's engorged or not. Because even moms who don't breastfeed can become engorged. You have to deal with that. Okay? But you look at the breast. Are they their normal pink? Do they look red, inflamed, hard? The nipples. Do the nipples look basically normal? That is to say they're not chewed up, bleeding, cracked, or anything of this sort. That's what you need to assess, especially on a breastfeeding mom. If you have cracked and chewed up nipples, 99 times out of 100, you don't have a proper latch. And that's something mom needs to learn, both for her comfort and to get her baby the milk she needs. Okay? So you're going to assess her breast. How's the breastfeeding going? What's going on? I see you're a little red. Is it causing you a little pain when you nurse it? Is mom having pain through the whole nursing or just when the baby latches? Some babies are very enthusiastic. They get it on, and then they settle down and nurse. So mom may have pain with the latch, but it goes away. Trust me, some of the moms. Okay? So the first B, you assess the breast. Okay? Second B, you move down to the abdomen. What is going on with these people? Okay. Second thing you're going to assess is the fundus. Okay? Where is the fundus in relation to the umbilicus? Okay? And this you will be doing fundal checks and such in the labor rooms as well, in the immediate postpartum period after mom has delivered. Okay? You want to know how many fingers above or below or at the umbilicus that the uterus is. So you're going to assess where it's located. Is it firm? Is it what we call boggy, soft? What's the problem with the uterus that's very boggy? It's not contracting well.
But it's not contracting.
It's not contracting well after delivery.
The placenta won't be delivered.
I'm sorry?
The placenta won't be delivered?
The placenta has been delivered.
Oh, it has been delivered.
This is postpartum. The placenta is delivered, but the mom's uterus is very soft. What's the potential problem?
Prolapse.
Is it that it won't go back down, or like in a
Say
timely?
that again.
Is it that it won't like return in a timely manner?
Well, at the moment it will eventually in 6 weeks return, but what's the immediate problem that you have if you have a soft uterus that's not contracting? Think about it.
Blood, like the waist.
Keep going.
Staying up.
Keep going down that trail.
Hemorrhage.
Hemorrhage. Give that woman a cookie.
Yeah, good job.
What?
There. So, if you have a boggy uterus, especially post-delivery, but also on mother-baby floor, it's not contracted well, it's not hard and firm, you better keep an eye out for hemorrhaging. Okay? So, the
What's
first
the physiology of that?
What is the physiology?
Like why,
Tell me.
when it's not,
Contracting.
I better see these cookies.
Ah, tell me. You had a baby, he came out. Your placenta came out.
Right.
So, where the placenta was, you now have an exposed wall with all those blood vessels that used to feed the placenta and the umbilical cord.
So if
Uterus
the
is not
membrane is
clamping
thin,
down.
if the membrane is thin, then it's just at risk for,
There's no membrane anymore.
Oh, it's not cramping, it means, the blood is gonna come, it's not
Blood is still
cold,
going there,
yeah,
but
it's
there's
still
nothing
going
to clamp it shut.
container, so
Okay.
it's gonna,
So, you have potential for hemorrhage.
okay.
But you still have some bleeding because you don't have anything to cauterize them on. So that's what the loci is. That's the bleeding. But if it's not clamped down, you're going to have floods. Okay? Postpartum hemorrhage can put blood from here to the end of the bed. Okay? That's not a happy proposition for mom or you. Okay? So the breast, the uterus, and then the two B's, bladder and bowel. Okay? On postpartum, they get into the bathroom. And bowel movements interfere. Many moms have their bowel movement when they're pushing. They haven't eaten for a while, so maybe 24 hours before they have another bowel movement. Doesn't matter. You just ask. Okay? The bladder. Where is the bladder in relation to the uterus?
Underneath it.
Hmm? Below. Okay? If the bladder is full, what happens to the uterus? Pushed aside and pushed up. Okay? It also has a hard time contracting, leading us to hemorrhage. Okay? You don't want them to have a full bladder. Okay? You're going to assess, is the bladder full? You should go to the bathroom. Okay? So, breast, uterus, bladder, bowel. Okay? L, the lochia. You're going to assess by pressing on the uterus and pressing down. You'll get most of your lochia coming out immediately after delivery. Okay? You get most of your lochia from a C-section patient the first time she gets up to the bathroom, because she's going to be basically horizontal, either on the stretcher or in the bed for 24 hours.
What's lochia?
So many of her lochia can pool in the back of her uterus. You may not push out much, but it may pool. So the first time she gets vertical to go into the bathroom after we take out the Foley from the C-section, you may have a gush of blood all over. Yes,
What's lochia?
that's bleeding.
Oh, just another word
Bleeding
for
that comes
blood.
out
Got it.
after delivery.
So you
Okay.
gotta push, say you gotta push the uterus through the
You
bladder.
get your hand on the top of the uterus, you get your hand below the uterus and support the uterus.
Okay.
It is possible to put enough pressure this way to cause the
Okay.
uterus to come out the vaginal area. It's called a prolapse uterus. You have no idea how hysterical everybody gets. It's a major disaster. It needs to be physically picked up and placed back in by medical personnel. Okay, so you're going to support it while you press and see how much load, how much bleeding you have. Okay? So, that's the lochia. The first E, the bubble. You're going to check the episiotomy for any lacerations. We just call it an E for episiotomy, but it includes all the lacerations. If the patient has lacerations, are they intact? Were stitches made? Most of the time, the stitches will be intact. Sometimes patients have what is called very friable skin. It tears very easily, and that will be noted when the practitioner is stitching. The stitch isn't going to stay in. Okay? In order to assess the episiotomy, which is back here, it's very hard to see in this position. So you can push that aside momentarily, but you're going to turn the patient over and ask the patient to turn over. Pardon me, one of you hand me my tea bottle, please. So, you're going to ask and they had any problems. Number one, ask them if they have any episiotomy or any laceration, okay? And ask them if they've had any problem with hemorrhoids. If you do a lot of pushing, you're going to get hemorrhoids, okay? The H part, and we don't do the H part all that often anymore. The H stands for Homan sign. You all know what Homan sign is? Homans is to feel any pain in the back of the calf when the foot is pressed back, okay? Nowadays, they don't encourage a vigorous Homan's check because sometimes they find that when you do that, you sometimes dislodge a clot. Clot goes off in the heart, you have strokes and a heart attack, whatever. So, what I usually do is just bring it back gently and ask them if they have a little pain back here, any pain back there, okay?
And what is that again? You know?
I'm sorry, that's Homan sign. Okay, but you don't want to do a vigorous, this one, like we used to do. Do vigorous, just slow stretching of the calf muscle and ask them if they have any pain. Okay? Many of the nurses over in Mother Baby do not do Homans anymore. Okay? And then the last E, the he part, is what they call emotional. Mom bonding. Okay? She and baby bonding. The family doing well, where they connecting together. But somewhere in the middle of it, we're going to ask her to turn over. Okay. And ask her to turn over, put the front foot with your knee to the bed, and if necessary, bend this knee. And you're going to check her back and see her back here, and see if the incision is intact, if she has any hemorrhoids, if they're bothering her, anything of that sort. Okay. Thank you, Noelle. Any questions on anything?